Assalamu alaikum everyone. Hope you all are doing great and you are fine. So today we have our guest speaker Dr. Naghman Zuberi with us and he will be discussing about how to attempt questions based on clinical scenario. So without any ado, I would like to welcome our guest speaker Dr. Naghman Zuberi. Assalamu alaikum sir. How are you?
Walaikum assalam. Alhamdulillah, I'm good. How are you?
Sir, I am also great. Sir, you can
Great.
proceed from here.
Yeah, let me share my screen and then we will start from there. Okay, guys. So I welcome all of you in our this today's lecture, and we will be discussing about the wrong slide. Yeah, now I'm going to share it with you. So, today we will be discussing how to attempt those questions which are based on clinical case scenario. In most of the exams all over the world, no matter you are appearing in some European boards or North American boards or wherever, like maybe some Middle Eastern countries in the boards. So nowadays it's a trend that apart from the basic information, basic knowledge, examination, they have a clinical judgment type of exam as well. It could be named like anything, could be a clinical judgment exam, it could be a day two exam, it could be a clinical scenario exam, it could be a case synopsis exam, so whatever the names are. But more or less, these exams, they are based on, they provide you some clinical scenario with the patient's age, with the patient's gender, with the patient's weight, then some vital signs. They provide you with some past medical history, some drug history, some present medication if patient is taking, their social history. They also give at times some important brief note, like maybe the patient is kindly like kind of afraid of the needles or has some anxiety or other issues. So, just to make the whole story, then there is definitely a chief complaint. And then the history of present, like chief complaint is if, say, for instance, it is pain. So, for how long the pain is there, if there are certain things which are making this pain relieved or is aggravating or pain is spontaneous, for how many days, were there some sleepless nights, etc., etc., etc. So, history of present complaint. Out of these, everything is very, very important. Because the questions, they will be based on all this information they provide you in the case synopsis. Weight is important because at times, especially in children, you have to calculate the amount of medicines you are going to give to the patient, because antibiotics and analgesics in pediatric patients, they are dependent upon the weight of the patient. Similarly, the amount of local anesthetic which you can administer in one sitting is also dependent upon the weight of the patient. Vital signs are also important, like if patient is having some uh, hypertension or cardiac arrhythmias or whatever, so we need to know about that beforehand. As well as we also take the baseline patient's respiratory rate. Few people, they get hyperventilated during the treatment because of the anxiety, so we must be knowing whether they are going into the hyperventilation or not because of the anxiety due to the dental treatment. So that is why vital signs are also important. Past medical history definitely is important because our treatment planning will be dependent upon the past medical history. If there is no any significant past medical history, then the treatment will be very, very simple. But definitely in exams, they don't want to give you the simple cases, they want you to give the complicated cases to judge your knowledge. And that is why maybe a patient would be having a history of some cardiac problem or hypertension or maybe repeated congenital heart defect. So again, it is very important how long ago the congenital heart defect was repaired, whether they will require the pre-medication or not. This is very important. If you don't know how long the heart was repaired and how much time has lapsed, how you would decide about the uh, pre-medication or the antibiotic prophylaxis in that case or not. Similarly, if the patient would be requiring some anxiolytic or not before the treatment, or patient would be requiring some uh, nitroglycerin prophylactic before the treatment or not, these are all very important. If the patient is taking some medications, including some over-the-counter medications, as well as if they are taking some herbal medications like maybe ginseng or garlic or whatever the products, because they also affect the bleeding time of the patient, as well as the clotting factors are also disturbed. So these are also very important. Then the social history of the patient is important, whether the patient is living alone, they are a sociable person, they are socially aloof. So these are also like certain conditions, they are dependent on these type of information as well. So chief complaint, I have already mentioned, and the history of present complaint, these are also very, very important. Well, the additional information is also provided in the form of a dental chart. If the patient is an adult patient, then they will give you just a chart like this, and the numbering is dependent upon which boards you are appearing in the exam, whether they have divided into four quadrants, so the numbering will be according to the quadrants, or if they are choosing the number, the universal type, like from 1 to 16 and then 17 to 32, etc., etc., and then from A to Z, whatever the situation would be. So we have to follow that same pattern according to that exam. Well, if they are providing you a chart like this, they may provide you, apart from other information, whether the teeth are present or missing. So there will be a cross on the missing teeth, and the information will be provided to you, like if these black spots are there, whether they are filled or carious teeth, so information will be present. If there will be a triangle over here, it means there is a furcation involvement. And then the probing depths will also be provided, both from the facial side and from the lingual side. The probing depths will be written in these, all the like six probing sites, their probing depth will also be mentioned. Similarly, this is a pediatric this chart over here. If patient is having a mixed dentition, then you will be getting both the charts, and the information will be present that this is the age of the patient. So you must be knowing that at what age which teeth would be present or which teeth not yet erupted. Some additional information regarding the oral condition will also be present, periodontal chart. If this type of information is present, some periodontal information would be available. But in some of the boards, what they do, they just provide you the information on one sextant. There are 6 sextants in oral cavity. Like we know about the 4 quadrants, there are 6. This is sextant 1, sextant 2, sextant 3, sextant 4, sextant 5, and sextant 6. So they will provide you information just about one sextant, and they will say that rest of the periodontal condition is almost relevant to the information provided for this one sextant. So you have to imagine just on the basis of that information which is provided to you. So this is a tricky part actually. Then you have to see whether it is going to be a chronic periodontitis, it is a localized chronic periodontitis, or it is a localized aggressive periodontitis, or it is generalized aggressive periodontitis, or it's a generalized chronic periodontitis, etc., etc. Well, they also give you some pictures in the exam, and then they can ask you about the discolored. Now, all these teeth are discolored teeth. We cannot say that this is natural, normal, this is normal, all of these, but they have different reasons for being discolored. If you don't know the reason behind the discoloration of a particular type of discoloration on the teeth, whether it's an enamel hypoplasia or tetracycline discoloration, or it is a Turner's tooth, or it is just the mild fluorosis. If your diagnosis is not correct, so the next step would be the treatment planning or treatment options, treatment modalities. So you won't be able to choose the proper treatment option from the so you will be basically losing your marks on question number, like whatever the question would be, the first question, which would be related to the diagnosis, as well as the second question, which would be about the treatment modalities, and you have to choose it. That is why your basic information should be very, very strong. Your basic knowledge should be very, very strong before you are going to attempt these type of questions. Another important thing is at times they give you the x-ray of a child and then they ask you how many teeth are present on the permanent teeth are present on this x-ray. We see, okay, this child is 9 years old or 8 years old, so we do not count the teeth which are present on the radiograph. The question is specifically asking about the radiograph. So you have to count the number of the shadows of those teeth which are permanent and they are present, like say for instance 28 teeth are present in this case. But over here, in this case, 2 teeth are missing. Then another question would be whether we will consider these as missing teeth or we can still wait, like maybe it's a 7-year-old child, so maybe we can wait for, we must be knowing till what the late genesis of these mandibular second premolar may occur. If we are not sure about that, do not have the information regarding that, then of course our answer will be wrong. Or if we will just knowing from the information we have taken from the other students who appeared in the exam, that they show you an x-ray with all the 28 permanent teeth there, so you have to choose 20. Maybe they change the x-ray. Over here we have only 26 permanent teeth present, so our answer will be wrong. That is why you have to be very, very observant and attentive when you are looking at some radiographs. Similarly, in this case over here, at times we miss the information regarding whether it is a periodontal condition or it is a periapical condition or it is the cervical burnout, whether it is a permanent dentition or it is a deciduous dentition. So we miss all this because we are not looking at the x-rays, we are just mugging the answers. The more you will look at the x-rays, the more you will be trained. Without having the proper information about the radiographs and interpretation of the radiographs, it would be very difficult for you to understand the situation. You won't be able to interpret the radiograph, whether it is a cervical burnout or whether it is some proximal caries over here. If you don't know where the proximal caries start, definitely proximal caries would be close to the contact area and above the cemento-enamel junction, and the cervical burnout will be below the cemento-enamel junction. If we do not know this basic difference between the two, it would be very difficult for us to reply. Same situation, like we do not know how the radiograph of the cervical burnout will appear, the margin of the root will be intact, though it is not very radio opaque. Whereas if there will be a root caries, then there will be missing edge of the root in that case, and the radiolucency will be quite diffused. So if we do not know this basic difference between the two, our answer is not going to be correct. Similarly, at times we miss this situation. We think that it is the first permanent molar, and we do not look at this crypt over here. We miss this thing, and our answer would be wrong, that this is not a permanent tooth, this is a deciduous tooth. Similarly, if they will ask you, maybe there is some carious lesion and they will ask you whether the pulp is, the radiograph tells whether the pulp is involved or not. if we look at the apeces of the deciduous molars and we see that this area is clear, instead of looking where the radiolucency or rarefaction should be present in a deciduous molar, if it is pulpily involved, it should be in the interradicular area or in the furcation area. So if we miss that, maybe we will see, no, the pulp is not involved because we are looking at the periapical region. That is not true in case of a deciduous molar. Similarly, for the bone loss, they may ask you whether it is a horizontal bone loss. So we must be knowing that how to interpret the radiograph for the horizontal bone loss or for the angular bone loss. We always imagine an imaginary line which is connecting the two adjacent cemento-enamel junction, and if the crestal lamina is just apical to it and is very radiopaque, does not have any radiolucency or notching or any interruption in it, we must say that it is good periodontal condition, no periodontitis over here. And looking at the level of the bone and then checking whether it is parallel to this imaginary line or not. If it is parallel to this imaginary line, then we will say that it is a horizontal bone loss, and if it is at an angle, then we will say that it is an angular bone loss. Similarly, we can also look at the furcation involvement as well. Well, at times what happens that they give you an x-ray and they ask you that whether it is pulpily involved tooth or it is periodontally involved tooth. If we know that the periodontal condition is amazing, if this crestal lamina is radiopaque and is in consistency with the radiopacity of the lamina dura, and the coronal area of the lamina dura is good and the periodontal ligament space is not widened, it means the periodontal condition is amazing. Whereas in periapical condition, there will be some thickening of the periodontal ligament space if the pulpal involvement is there in the apical region. So there would be chances of some disruption in the lamina dura in the apical region as well. So looking at the lamina dura, we can easily interpret whether it is a periodontal condition or it is an endodontic condition, or it could be both these situations as well. So the pulp conditions in a child, we must be knowing whether looking at the history, looking at the symptoms they are presenting, the history of the present complaint, whether the pulpitis is reversible or it is irreversible. If it is reversible, then our treatment plan will be different. If it is irreversible, then our treatment plan will be different. Whether it is a traumatic exposure or carious exposure, then again our treatment plan, especially in the deciduous teeth, will be totally different. Whether there is an internal resorption or it is an external resorption, internal resorption for children will be totally differently managed as compared to the internal resorption in the permanent teeth. So we have different treatment modalities for the children. Pulp capping, it is a big question mark. Are we going to do the direct pulp capping? So in very few instances, we may opt for the direct pulp capping only and only if it is iatrogenic mechanical trauma. So history again is very, very important, or the information provided is very, very important. We cannot do a direct pulp capping in deciduous teeth if it is a carious exposure. Indirect pulp capping, where it is required, how much depth we can go, how much caries we can leave in a deciduous molar for the success of indirect pulp capping. Again, our basic information should be very sound. Are we going to perform the pulpotomy in deciduous teeth? So which deciduous teeth we can do the pulpotomy? What are the indications and contraindications? We must be knowing. Our basic information should be very sound in order to take a decision for the particular tooth. Similarly, what type of pulpotomy is indicated in which type of permanent teeth? Definitely in those permanent teeth where the apices are not yet closed or the root is not yet completed. So which type of pulpotomy? The pulpotomy which we talk about the deciduous is totally different, and the pulpotomy which we discuss for the permanent teeth with open apices, it is totally different. Are we going to perform the pulpectomy or not? At times they give you the very borderline age, like maybe they say that child is 10 years old and the central incisor, lower central incisor has a traumatic exposure. So what are you going to do? Patient is already 10 years old. So apices are closed. We are not going to do the pulpotomy procedure in that case at all. Now we are only left with the pulpectomy. So age is important. We must be knowing what would be the treatment modality at that age when the apex is closed. Are we going to perform pulpectomy or are we going to perform the pulpotomy? Similarly, when the apexogenesis is indicated, and what are the procedures like direct pulp capping or the CVEC pulpotomy, etc., etc., and what are the indications for apexification. Nowadays, another question they ask you about the pulp regenerative procedures. So whether we are going to opt for the pulp regeneration or apexification, definitely pulp regeneration is a better option because it induces the elongation of the root as well if the root is short and all those things. So we have to consider what are the methods of for the physiologic root development, etc., etc. Then traumatic injuries and their management. These are also very common questions which appear in the board examination about the concussion injury. Are we going to just observe or are we going to perform immediate pulpectomy, etc., etc.? Definitely the more conservative approach is the best approach. We will recall the patient after some time and we will check using the this EPT whether the tooth is responding or not. Similarly, what would be the treatment modality for subluxation, luxation, intrusion, extrusion, avulsion? I have provided one lecture earlier on the management of an avulsed tooth. That lecture is also very, very important if you are taking your board exam because all the information on the avulsed teeth, too many questions would be there on the avulsed teeth, so you have to go through that lecture as well. How to manage the vertical root fracture or horizontal fracture. So level of the horizontal fracture is also important, whether it is in the coronal third area, the horizontal fracture is in the at the crest of the ridge, it is in the middle of the root, or it is at the apical portion of the root. So our management will be totally different for all these situations. Then whether it is a crown fracture, then the crown fracture is only and only involving the enamel, or it is involving enamel and dentine, or the pulp involvement is there, etc., etc. How long the exposure has been done if it is a pulp exposure. Then pulp conditions in an adult. It could be just sensitivity only, maybe because of some hyperocclusion. It could be because of some not properly done composite filling in the posterior teeth. It could be just recent scaling done. Whether it is a pulpitis which is reversible, so looking at the symptoms, whether how long the pain is going to last after the stimulus, or if it is irreversible. Whether there is an apical periodontitis, apical periodontitis could be because of the pulpal involvement, it could be because of an hyperocclusion as well, or trauma from occlusion as well. Whether there is a periapical abscess, traumatic exposure, carious exposure, vertical root fracture, then again same the horizontal root fracture depending upon the position. Whether it is an endoperio lesion, so again giving you some information about the endoperio lesion, they want to test your knowledge that are you going to perform the endodontic treatment before the periodontal treatment, or are you going to perform periodontal treatment before the endodontic. Always choose for the endodontic treatment prior to the perio treatment. And then the symptoms of cracked tooth syndrome, they want to ask you what could be the situation. The patient is going through this type of problem. At times, even they ask you to distinguish between the two conditions, like if it's a cracked tooth syndrome or cracked tooth or cracked cusp over there or cuspal fracture, or there is a craze line. So trans illumination, it tells us whether it is a cracked pulp or it is a cracked cusp, or it is a cracked tooth, or it is just a craze line. If the only craze lines are present and you are doing the trans illumination, the light will pass through and through, whereas if it will be a cracked tooth, then the light will stop at the level of crack. Now the periodontal conditions, like in the adults, especially gingivitis, just by the plaque or some underlying issues are there. So it could be mouth breathing, it could be some hormonal changes, gingival hyperplasia, whether it is familial or it is drug induced. Then chronic periodontitis, age is very important, and the progression of the disease is also very important. Chronic periodontitis, which we used to call earlier adult periodontitis, this is the situation which most frequently occur with the adults. So looking at the age, first of all, we will check, okay, so what kind of periodontitis it would be. Secondly, the amount of plaque or the amount of deposits would be consistent with the amount of destruction. Whereas in aggressive periodontitis, the age would be very young and destruction would be very, very severe. The plaque will be minimal, but the destruction will be very, very severe. And we must be knowing that which bacteria cause which type of periodontitis, like the Prevotella and P. gingivalis, they are more prominent in chronic periodontitis, and Aggregatibacter actinomycetum comitans, it is more common in the aggressive periodontitis. Again, the periodontal condition, it is only from the trauma from occlusion, or it is a combination of the periodontitis and trauma from the occlusion, etc., etc. I have already provided you a couple of lectures on trauma from occlusion and its management. It is available on the channel, so you can go through it, how to manage the case. Well, gingival recession and aesthetics, that is also very important. If it's a young person, then definitely they want some grafting to be done after the periodontal treatment for the aesthetics. But if it is an elderly person, then we are not going to perform any flap procedures in those patients, or some grafting is not going to. Furcation involvement, whether it is furcation involvement is grade 2 or grade 3 or whatever, so we have to decide our treatment plan accordingly as well. So treatment options for the periodontal conditions would be scaling and root planing only, or the phase 1 treatment, how long the phase 1 treatment is going to last, and what would be our next step, when are we going to move to the second step, which would be scaling and root planing with flap procedure. Depend how many times it has been done, we have to keep in mind, you have to be conservative in your approach. It is not that patient comes to you on the second phase of the second appointment of the treatment, and you see that still there are some exaggerated perio probing depths are there, and you just perform the flap procedures. No, look at the attitude of the patient, whether they are performing the home care properly or not. Some modification in the home care is required or not. Gingivectomy and gingivoplasty, previously, like maybe 30 years ago, it was a very common procedure. It was being done when they wanted to see that when they just saw that there is some exaggerated probing depth, they just started performing the gingivectomy. But now aesthetics is very important, because gingivectomy, when you are going to do, you are definitely increasing the amount of display of the teeth, whether it is acceptable or not. So we have to decide accordingly. Whether the craters are present, or the architecture of the bone is in reverse, or it is not in reverse, so we have to decide accordingly whether we are going to do the osteoplasty or not. Where we are going to do grafting, and what are the grafting procedures are appropriate. Are we going to do the subepithelial grafting in the anterior region, or are we going to do the full thickness graft in the anterior region taken from the palate. Where the guided tissue regeneration is indicated, we must be having the knowledge about it, which cases could be treated with it, and where we are going to prescribe the antimicrobials. In chronic periodontitis, scaling and root planing is the only solution for couple of times. We are not going to give any antibiotic in chronic periodontitis. Keep this thing in your mind when you are attempting the questions. Yes, for aggressive periodontitis, apart from scaling and root planing, the antimicrobials, the antibiotics would be required. Similarly, in a case of acute necrotizing ulcerative gingivitis, if patient is not having fever or patient is not having lymphadenopathy, we are not going to give any antibiotics. We will only and only rely on scaling and root planing. Host modulation is by subtherapeutic dose of doxycycline. So we have to see whether it is a case of recurrent periodontitis or it is a refractory periodontitis. So again, we have to choose accordingly, and keep in mind the doxycycline in host modulation is not used for antibacterial effect. That is why it is given in subtherapeutic dose, that it is only and only used for its anti-collagenase effect. They also give you some pictures of the oral lesions, and then they ask you either the diagnosis or the management of a particular picture, that how you are going to manage this particular case. They can ask you both the things as well. So if your diagnosis is not correct in the beginning, then your treatment of course is not going to be correct. Well, we can see that some white area is present in the oropharynx, but it is also present in the palate. And looking at the dentition, it does not look that this patient is a very young child. So first of all, to rule out whether it is herpingina or it is candidiasis, we can see that the lesion is present on the palate as well, not confined to the oropharynx. Second thing is patient age is not that age. We're looking at the dentition that we are going to say that it is herpingina. Then looking at the situation over here, we can see the Wickham striae, we can see the situation of the lichen planus, whether it is, again, the history will tell the patient was not aware of the lesion, accidentally you find out this lesion, so what would be your management? Are you going to give them some intralesional steroids or systemic steroids, or are you going to perform the biopsy immediately, or you will just reassure the patient, or you are going to just observe the case, or you are going to refer the patient to the physician for their systemic evaluation if there is some underlying diseases present or not. Again, they can show you a picture of some erythroplakia or some leukoplakia or a mixed red and white lesion, and they can ask you what would be your first step. The first step definitely would be an incisional biopsy in such a case. They can also give you some situation of median rhomboid glossitis, or they can show you a picture of some geographic tongue, that what are you going to do in that case. So definitely be, or maybe a linea alba, or maybe some this white sponge nevus. So what would be your treatment option? Definitely we are not going to do anything in those such type of cases. At times they give you a picture of some missing teeth, and they can ask you what would be your treatment plan in that case. Are you going to restore this over erupted tooth, or you are going to extract this over? So looking at the situation, if we are able to restore it restoratively and endodontically, then definitely we are going to restore it. But if the situation is like this, then definitely we are going to extract it, depending upon the picture or the amount of extrusion of the tooth. They will give you, then we have to decide accordingly. In orthodontic cases, usually they show you the picture and they ask you about the treatment timings, whether it is going to be treated immediately or do we have to wait for the growth to occur, or it is going to be treated at the prepubertal growth spurt, or if it is going to be treated with surgery, or it is going to be treated with the normal removable appliance, etc., etc. If we know that what are the differences in the different crossbites, how the actual crossbite, the skeletal crossbite differs from the functional crossbite, what would be the midline if there is a posterior crossbite in case of this functional crossbite, definitely because of the shift of the mandible, the midline would be shifted. And whenever there is a functional crossbite, no matter it is posterior crossbite or it is anterior crossbite, or if it is an anterior dental crossbite, we are going to treat those immediately. But anterior skeletal crossbites or typical class 3 cases, we wait till the patient's growth is completed, then we are going to manage it surgically. Similarly, we must be having some information about the drugs, the commonly used drugs and their interactions with various medications. That is why the drug history or the previous medical history or the present medication information is important. So if you are going to prescribe some analgesics or some antimicrobials, you must be knowing that if they are going to interact with some medicine or not. So you have to go for the alternative. They can also show you, like after giving you the history, they can show you some prescription, whether the prescription is proper or not. Maybe they will give you the history that patient is allergic to penicillin and derivatives, and in the prescription picture they will give you amoxicillin is written over there. So definitely it is not appropriate because the medicine which is contraindicated, it is present in that prescription. Or maybe they will change the strength of the medicine, or they can change the frequency of the medicine, or even like they will say that okay, for 7 days you can take the medicine 3 times a day. So instead of 21 tablets, they will say that like the total amount to be dispensed, it is written for the pharmacist 30 tablets. Again, it is not appropriate. Local anesthesia is also the it is not also, it is the most important pharmacological agent which is being used in our dental operatories for every single procedure. And keep in mind, in North America, even for a simple filling, you need to give the local anesthesia. It is not that patient comes to you, you just push the patient on the chair and ask them to open their mouth and you start working on it. No, you need to give the local anesthesia before you start even for simple class 1 occlusal filling. And you need to know different types of local anesthetic agents available, whether they are esters or whether they are amides, and if a person is allergic to one type of amide, so what would be the options available. If the patient is allergic to both esters and amides, so what option we will be having, etc., etc. And local anesthetic cartridges, most commonly they also contain epinephrine in it, so we must be knowing the doses of local anesthetic, different local anesthetic agents according to the weight and their sealing dose, as well as the doses of epinephrine in different cardiac conditions. We must be knowing, because we have to choose the answers accordingly. Then comes the behavior management. In United States board examination, they give you 1 or 2 questions about the behavior management of the child, as or maybe an elderly patient as well. So over here, it is very important how you are going to manage a difficult child. Even at times they ask you how to manage the difficult adult. Are you going to perform the tell, show, do, or are you going to use the uh, verbal command, or are you going to use the restraints or whatever? What is habituation? How the child is going to be habituated with the systematic desensitization, etc., etc. What are the positive reinforcers and what are the negative reinforcers? Definitely positive reinforcers are those which you award the patient. It could be in the form of an sticker or maybe in the form of some uh, goodie bag they get from the dentist after performing nicely, or maybe it could be a visit to a zoo or something by the parents after behaving nicely in the dental clinic. Negative reinforcers are those reinforcers like which we need to eliminate from the operatory. Like at times, child is not behaving nicely in the presence of parents, and they think that maybe our parents are going to rescue us from this situation. So we eliminate those negative reinforcers. We ask them to go and sit in the operatory and while we are working, and we remove those negative reinforcers systematically. Like after like few minutes, they can just take few steps towards the door, and finally they exit. Empathy is also important. At times they give you a situation that this is the situation, patient comes back after like 5 years and neglected mouth and a lot of plaque and too much decay. So they give you like 4 or 5 questions, like sentences, that how you are going to address the situation to your patient. What would be your tone? Always we must address our patients in a very empathetic manner. Then dentist's attitude, whether the dentist is always angry with the assistant or they are going through some tough time and they are showing it with their attitude. So those questions are always present in some of the American boards exams. We must be also aware. So what is the positive attitude and what are the negative attitude, and how to answer those questions as well. So over here, I have given you a brief overview about these exams, like how to attempt these different clinical cases based exams. And if you have any further queries, you can always contact me or the owner of this channel, and I will definitely get back to you. And any queries, they would be addressed accordingly. I am always uh, pleased to help anyone who is seeking the help in these all regards, and I will be available to you. Thank you very much. Over to Farooq.
Thanks a lot, sir, for the today's lecture. Thank you very much, sir. Khuda Hafiz.
Allah Hafiz.